So today we will be talking about aortic dissection. So what happens in aortic dissection? It is an emergency condition. It's an emergent condition, and what happens here is that there is a tear in the intima. Intima is just a part of the vessel of the artery, and that rupture of the vessel, the tear of the vessel, kind of forms a false lumen. So now let's say we have the aorta here. So aorta has this ascending aorta and it gives out branches, about 3 major branches here, and then it goes down, and then it goes down, 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 and this is the descending aorta. So now this is the ascending aorta, this is the arch of the aorta, and then this is the descending aorta. This is the brachiocephalic trunk, this is the left common carotid artery, and this is the left subclavian artery. So now if we have to take a piece just to understand the aortic dissection, so if you have a piece of this arterial wall, the aortic wall, so it on histology it is going to just look like 3 layers. So there is a layer, it is called the intima. So this is the internal layer, like this is the lumen. This is the lumen of the aorta, and this is the intima. And then just beneath it, we have another layer, and that is the this layer is called the media. So this is the intima, and then that one is the media. So, and then beneath that, we have another layer, and that layer is adventitia. It's just connective tissue. So now what happens in aortic dissection is that due to increased pressure here in the lumen, there are a lot of risk factors for that we're going to talk about later, but let's say there is increased pressure here, right? And that kind of, this increased pressure of the blood actually ruptures this intima, and then the blood kind of collects here. The blood collects beneath the intima. So this is basically the dissection. So if you look at it now, we actually get 2 lumens. So one lumen is here, right? This is the true lumen, the original lumen. And then we have another false lumen here where the blood is flowing through this false lumen. So we get 2 kind of openings. So now, what are the risk factors? So like I said, the risk factors for this for the aortic dissection is anything that increases the pressure here. So the most common one is hypertension. Remember, most people are hypertensive. Chronic hypertension, like more than 70% of the cases are due to hypertension. And then other things, like we have the connective tissue disorders, like Marfan syndrome is a popular one. And what happens in Marfan syndrome is that it's not the hypertension, but it's just that the connective tissue, right? The connective tissue, we know the fibrillin gene mutation, which takes part in collagen synthesis. So that connective tissue is actually defective and it's weak, and so just a little rise in pressure can actually rupture this intima and cause aortic dissection. Another thing is bicuspid aortic valve, like for example in Turner syndrome. So that's another condition to be aware of that can cause this. And then dyslipidemias can cause it. Dyslipidemia can, like for example, lead to hypertension, and then hypertension can cause it. And then cocaine we know can cause increased elevated blood pressure because it increases sympathetic activity. Okay, it increases sympathetic activity, increases the blood pressure, which can then rupture the intima and cause this false lumen formation and aortic dissection. So then let's go to the type. Let's first talk about the types. So the types are, there are 2 types. So one is the Stanford. These are called Stanford types. In 1970, he kind of classified these dissections. So Stanford A and Stanford B and Stanford V. And it's important to know these because the management is different. And so what happens here in the Stanford A is that we actually get dissection in the ascending aorta. So the ascending aorta is involved. So whenever you have the ascending aorta involvement, just think about Stanford A, regardless of whether the descending is involved or not involved, because it may or may not be involved, right? So you just need involvement of the ascending aorta. So if ascending aorta is present, it's Stanford A, regardless of whether the descending is present. And then the other one is actually this descending aorta involvement. So what happens in the Stanford B is that we actually get just the descending involvement. We don't get this ascending aorta. So ascending aorta is spared. So this one is a milder one, you can say. This is a mild one, but this is one is very severe one, because we know that here we have closer by there is a heart, and it's really important structures here. So ascending is more severe. So now let's talk clinical features. So how is this going to present to us? So clinical features include crushing chest pain. Remember, it is the crushing word. They often would crushing pain, chest pain. Often use this crushing word in question stems. So crushing chest pain, and it is radiating towards the back, radiating to the back between the scapulae. They can say between the scapulae. So, and then the pain can then radiate to different locations depending on which depending on the dissection extension, like where it extended upwards, downward. If it extended towards for example, the renal arteries, right, it can cause it can radiate towards the flank, and it can cause renal infarction. So that's one presentation, like crushing chest pain. Is just remember, crushing chest pain radiating to the back between the scapulae. That's really important presentation. And then if you check the blood pressure, of the two arms, there's actually a greater than 20 mmHg usually blood pressure difference between the two arms. And the reason is pretty simple. So now look, if you get a false lumen, for example, in the left subclavian artery here, then one of the arms, the left arm, is not going to get enough blood, right? Because the original lumen is kind of occluded. While if the other subclavian artery, let's say, is normal, so if this is normal and this is kind of occluded, it will actually cause blood pressure differential. So this occlusion, occluded subclavian artery will cause decreased pressure in the left hand, in the left arm. So that's blood pressure differential. That's usually very important. And remember, most patients with aortic dissection will be hypertensive. So the thing is, if you get like if a patient is hypotensive and with aortic, and you're suspecting aortic dissection, just suspect aortic rupture, because rupture can cause rapid blood loss and then hypotension. Then so let's talk a little. Let's touch a little on the complications. So there are a lot of complications. So for example, depending on where the kind of the aortic dissection kind of radiate or extend. So let's say if it extends backwards. So what is here? We have the heart here, right? So if it extends backwards, close to the ascending aorta, we have the heart. So what can it do in the heart? So in the aortic valve, it can cause aortic insufficiency. So it can cause aortic insufficiency and aortic regurg. Then another thing it can do is that it can actually cause accumulation of blood here. It's called cardiac tamponade, pericardial effusion. It can cause cardiac tamponade with the Beck's triad, with the hypertension, LVJVB, and muffled heart sounds. Then a third thing it can do is that it can go up through the carotid arteries. And if it can go up to the carotid arteries, it can actually occlude them and cause stroke. So it can cause stroke. Another thing is that in the lungs, if it extends to the pulmonary arteries, it can actually cause hemothorax. And then in the kidneys, like we talked about, it can actually cause infarction, renal infarction. So there are a lot of complications. It depends on where the dissection has actually extended. So then coming down to the management, it depends on the Stanford A and Stanford B, like which type is present. So let's say if Stanford A is present, Stanford A is very severe, like we talked about. It's really close to the heart and it's really severe. And so in this case, we just need surgery. Okay, you're directly going towards the OT. You need immediate surgery. And on the other hand, in Stanford B, you can actually wait and you can actually do. You can actually give just medical management, medical treatment. So medical treatment, you give IV beta blockers. Remember, you should avoid nitrates. And the reason is that if you give nitrates, right? If you give nitrates, it can actually cause decreased blood pressure, sudden decreased blood pressure, and that can actually cause reflex tachycardia. So if you get tachycardia, then obviously this lumen, this intima, is going to further enhance this the pressure on this ruptured intima and further enhance the dissection because of the increased pressure or stretch or pressure on the valve. So the pressure on the valve is kind of increased if you get given nitrate. Nitrate causes sudden decrease in BP, which causes reflex tachycardia, which increases pressure on the intima. It can actually cause progression of the aortic dissection. So that's why nitrates are usually avoided. But if you give beta blockers, let's say, if you give beta blockers and still the esmolol, for example, and still the blood pressure is not controlled, the blood pressure is still, systolic blood pressure is greater than 120, let's say, then you can actually add nitroglycerin because there is no other option for you. So like it's an emergency antihypertensive. So you can then give that, but it's still plus minus. You may or may not give it. So you have to be cautious giving it. So that's basically just the treatment, the medical treatment. And the medical treatment is only, remember, for Stanford B. It is not used for Stanford A. So that was just a quick discussion on aortic dissection. And another thing about dissection is the trauma. In the trauma, usually that is aortic transection. That's not dissection, but that's a transaction. So, and the reason that is important is because of the anatomic relation. So it usually occurs because it's usually asked in questions like the aortic transection. So it usually occurs here, like proximal descending aorta. So like this is the proximal descending aorta. And the reason is that there is a ligament called ligament arteriosum, and actually when there is a certain deceleration accident and the patient kind of hits a steering wheel or something, it actually stretches on this proximal aorta, and it can cause complete transection of this aorta. And it can actually cause hypotension because it's a complete transection. It's not just the intimal tear. So this ligamentum arteriosum and proximal aorta anatomically is important in trauma cases. So hope this was helpful.